Good morning and welcome to our Rhinitis and Conjunctivitis Allergy Education Workshop. This is the third session in the 2026 series. My name is Megan Ahmad. Thank you for joining us today. I would like to thank our sponsors for making this event possible. For any queries, please feel free to email admin@allergyfoundation.co.za. The recording of today's webinar will be made available to anyone who's registered. Our program today will be led by an awesome panel of experts. For any medical professionals in the audience, please note that this is not a CPD accredited event. Before we get started, I'd like to go over some basic housekeeping. This is quite important, especially for those joining us for the first time. The taskbar may be seen at the bottom of your screen. Our audience is muted and will remain muted for the full duration of the session today, and we will not use the hand-up function. Instead, we encourage you to post your questions in the Q&A tab. Our panel of experts will answer during the session and during the dedicated questions and discussion session at the end of the program. You may use the React button to interact with the panel by sending your reactions. Today's program and other downloadable content may be accessed via the Resources tab. Please feel free to visit the live links we've added as well. To access the recordings of the previous workshops, please scan the QR code. You may email laik@allergyfoundation.co.za for more information. Please follow us on social media and continue following us on social media, and also sign up for our free newsletter to receive updates. Feel free to visit our website, and that is www.allergyfoundation.co.za, to learn more about what we do and what we offer. Sign up for our free newsletter, browse our articles and free downloadable content, and explore the products under the AFSA seal of approval. Visit the AFSA shop to purchase our in-house products. Our eczema advocacy efforts continue to grow. Medical aids in South Africa are falling short on chronic care. Scan the QR code to sign our petition today and join hands for real change. Don't let eczema go uncovered. And lastly, before we continue with the program, I'd like to mention that we have some awesome prizes up for grabs today. We've got 4 prizes for 4 lucky participants. Winners will be randomly selected at the end of the session and announced live. So please be sure to stick around right till the end. Okay, before I hand over to Dr. Duval, I'm just going to play some very short in-house AFSA messages, and then we'll get started with today's program.
Looking for products that are safe for allergy sufferers? The AFSA seal of approval is here to help. This trusted seal is awarded to products that comply with our strict quality criteria. Look for it on body care products, air conditioners and purifiers, medical bracelets, nasal sprays and washouts, eczema clothing, cleaning products, and many more. Choose your products with confidence. Look for the AFSA seal of approval or visit allergyfoundation.co.za to view the available products.
Let's get into the action plan for achieving a truly clean, truly allergen-free bed. First up, the HEPA vacuuming. You're going to strip the bed of everything. Then vacuum the mattress slowly, using overlapping strokes. You really want to pay special attention to the seams and the edges. That's where all the gunk collects. And here's a pro tip for you. Always, always empty the vacuum canister outdoors so you don't accidentally release all those allergens right back into your house. Next is the UVC sanitization. And I gotta say, safety is the absolute #1 priority here. The device has to be positioned precisely, and the exposure time is critical for it to actually work effectively. And because this involves certified equipment and pretty specific safety protocols, this is one step that's really best left to trained professionals to ensure it's done right.
Alrighty, thank you for your attention. I am now going to hand over to our first panelist, Dr. Pieter de Waal. Thank you for joining us today, Dr. de Waal. Over to you.
Thanks, Mix, and thank you to AFSA and Megan, Luani, Lynn, sitting there very far. It's always exciting to present these talks to you, as they are meant to be very practical. And when these talks are done today, hopefully you'll have some important practical messages on how to treat your allergic conditions. So I'm going to talk about recognizing, yes, also try and treat, but also recognizing and treating allergic rhinitis. So we really hope you enjoy the session. So let's just get into some definitions, or talk about some definitions, because then you really understand what this is all about, or hay fever is all about. So rhinitis just means inflammation of the nasal passages. It ends with an itis. And a rhinitis means the nose. So if there's inflammation of the nasal passages, that's kind of stating what's really happening. But really the crux of the matter, or the core of allergic rhinitis or hay fever, is inflammation. So that's what we really want to address here. Allergic is obvious in most instances. Remember, not all nose problems are due to allergies. There's a long list of things that can mimic allergic rhinitis or chronic rhinitis. But in what we're going to going to discuss today is allergic rhinitis. So that's exposure to an allergen that's causing that inflammation. Due to the inflammation, or because of the inflammation, there's swelling, there's increased mucus production. I think we all know, suffering from allergic rhinitis, the snotty noses, the blocking of the nose, and the sneezing and the itching. And these can be very brief, or they can prolonged, with usually very or intermittent episodes in between. But usually when you have these brief episodes and kind of recover completely from it, it's due to a viral illness. So chronic rhinitis or acute rhinitis and sinusitis, infective causes, can be a common cause for brief episodes. And remember, it's a chronic condition, so that's quite important to remember, because it needs chronic treatment. And that's why it's so difficult to get rid of your hay fever, because all your allergic conditions all over the spectrum, really allergic rhinitis is probably the one that stays with you until advanced age. And remember, it's not a trivial condition. It really affects patients' quality of life, and often patients get so used to how they feel and how they look and how they act, they often don't recognize that they are actually suffering from it, and it affects their daily well-being and daily quality of life. So remember that allergic rhinitis or hay fever doesn't really only affect the nose. It really ripples through. There's a wide range of conditions that it really affects. So there's allergic rhinitis in the middle. Directly coming from that is usually linked to increased risk of upper airway infections. Dr. Naidu is going to talk to us about conjunctivitis, specific allergic conjunctivitis. That's where the eyes are quite inflamed and itching. Allergic asthma, atopic dermatitis, chronic rhinosinusitis, otitis media. And really, because these patients do not sleep well at night, they really do not go into deep sleep. So they can have sleep disturbances. And due to that, in the classroom, we often see it that parents or teachers complain that these patients cannot concentrate very well, they don't perform well at school, and at the end of the day, it really ripples through to the family and social dynamics, and the way that these children act and the way that they behave is really influencing the whole family at the end of the day. And it really decreases their quality of life. We often also see mouth breathing. They breathe through their mouths because their noses are so blocked. So that can also have consequences. I'll show you a picture in a minute. So how do we recognize this condition? It's important for us as clinicians, but also for you as patients to recognize it. There's a few cardinal symptoms. We call it the 4 cardinal symptoms. And you can really have one or more of these to recognize allergic rhinitis. The first one is sneezing. They can be paroxysmal, so they come in bouts, or they can really be after an allergen exposure. Watery nose, that's usually a clear watery nasal discharge or a runny nose. Nasal obstruction, that's usually the one that patients often complain about. It's usually bilateral, but it can also be unilateral, depends on certain times of the day, and it's often worse at night. And then this terrible prolonged nasal itching, which often causes a patient to scratch and then to upward scratch their nose, and it causes allergic rhinitis, salute. I'll show you a picture of that now. But there's also a few associated symptoms. The red and the itchy and the watery eyes. Like I said, Dr. Naidu is going to talk to us about allergic rhinitis. The itchy palate, the ears, the throat, often a postnasal drip. Coughing, usually due to the postnasal drip. And usually the postnasal drip causes patients to constantly clear their throats, so they the whole time. And it's often very annoying to people around these patients, because they often do not realize it themselves, but people around them or their friends or the teacher in classroom or even the parents may notice it. Reduced sense of smell because of all the inflammation and the swelling. The smell sort of organ is affected, and there can also be some facial pressure that goes with it, discomfort, and even this terrible frontal headaches that patients may experience. So there you can see the typical signs there. That patient, this lower eyelid that's got that extra fold, it's called the Denny Morgan line. And that patient there at the right has got periorbital eczema, so it often goes with atopic dermatitis or eczema. And then once again, that swollen sort of extra lines that you can see there with or inside or on the top or on the skin of the inner eyelid. This is from Dr. Shauna Emanuel that really in the ABC of allergy gave us this very nice picture about an allergic or an atopic boy. And there you can see they often appear pale. They have this sort of dark circles, almost raccoony eye because of the chronic venous congestion. It's called allergic shyness, that dark shyness. Once again, that Denny Morgan folds in the eye. They often have accompanied problems like asthma, so they can have an hyperinflated or a wheezy chest, or they can have dry skin with eczema. And then obviously the ear and the nose and the throat problems that goes with that, recurrent otitis media or a glue ear or sinusitis. They often have dry, cracked lips because they're breathing through their mouths more than they're supposed to do because of their nasal blockage. And then we often have this postnasal drip that you can physically see when you examine their throats. And when you look with your otoscope or your rhinoscope through that patient's nose, you often see the swollen, pale inferior turbinates, that little swellings that you can see inside a patient's nose. So it's important to not just focus on the nose. You should actually focus on all the systems that may be present with this patient's allergic condition. And here, once again, just real-life pictures of 3 boys with all the same problem, allergic rhinitis. That boy on the left is having mouth breathing, this sort of long, tired-looking face. That boy in the middle has got allergic mannerisms, so he kind of have this rabbit face where he sniffs and he pulls his face the whole time due to a constant nasal dripping. And that boy on the right, once again, open mouth, sort of a tired-looking boy with a dark circles around the eyes called allergic shyness. That boy on the left has got an overbite phenomenon, and once again sort of an open mouth breathing. And that boy on the right has got upward rubbing of the nose. We call it the allergic salute. So because of that chronic or constant upward rubbing of the nose, you get that transverse nasal crease that forms just on the tip of the nose or over the skin of the tip of the nose, and that causes that sort of transverse dent that we often see. This lady on the left, once again, you can see the shyness, that dark sort of circles around the eye, specifically under the eyelid, with a bit of that Denny Morgan fold once again. And that lady on the right side has got the transverse nasal crease, that dark discoloration of the skin over the nose bridge. And that's because she's constantly like upward rubbing her nose. Don't forget nasal septum deviations. That's often something that people are unaware of. It can be congenital, so you can be born with a skew nasal septum, and that's that middle part of the nose. Or you can have some or the other injury, and most patients that I see in my practice, often this goes unnoticed or undocumented. So they'll often say, oh yes, I remember last year I was hit by a netball ball, or my child fell on his nose and there was severe bleeding and pain, but they often leave it, and that cartilage kind of grew skew, and that's causing patients to have nasal symptoms also, with allergic rhinitis an important consequence. When doctors look into your nose with a rhinoscope, we often see snotty, a lot of snotties there. You can see that turbinate, that bulge that you can see there in the middle of the picture. That's your inferior turbinate. It appears kind of shiny, very swollen, very angry, and the same thing happening there at the right. And if you use your imagination, you can also see there's a polyp that's forming inside that patient's nose. If you leave allergic rhinitis untreated, that little girl on the right-hand side, I think on the left side, she was 6 years old, and 3 or 4 years down the line, left untreated, you get this maxillary overgrowth because she's got big adenoids that goes with allergic rhinitis. She's got chronic mouth breathing, and your upper part or your upper jaw actually grows faster. And that's causing that terrible overbite phenomenon, and that they often refer to that as an adenoid facies, where the whole face sort of shape changes. So you can see how her whole face changed because of untreated allergic rhinitis. And heaven forbid that boy on the right-hand side has got heart failure because of his obstructive sleep apnea at night. His CO2 levels increased a lot, his oxygen levels decreased during sleep, and that just puts constant pressure on your heart and your lungs at night, and you develop heart failure, specifically right heart failure called cor pulmonale. So it's definitely not a benign disease, and it should not be left untreated. Each and every patient with hay fever or allergic rhinitis should preferably be tested, or not preferably, should be tested to test for aeroallergens. We know allergic rhinitis, in 80-90% of patients, you will identify a specific trigger or allergen that you may be allergic to. It can be done via skin prick testing. That's an easy 10 to 15 minute procedure. The skin prick testing itself is very quick. That takes 1 minute. And then we wait for about 10 to 15 minutes before you read the results. On the right-hand side, it's fairly equally, but it does involve a blood test. You can also test for IgE antibodies, probably the most well-known antibody when it comes to allergies. So you can do either of them. Depends on your doctor or your setting where you are, or what your doctor feels or your healthcare practitioner feels the most comfortable with. But it really gives us very good insights into your allergens, and it's important to know your allergens to avoid, and then that will enable you to avoid them effectively. So just remember the difference between an allergen and an irritant. Irritants we don't test for because we don't have blood tests that show you are those are irritants to you. But common allergens on the left-hand side of that table, you'll see house dust mites, pollens from various grasses, trees, and weeds, indoor and outdoor mold, cat and dog, cockroach, and occupational allergens. Don't forget about the workplace, like for instance flour or fish or one of those things that you can inhale. On the right hand side you get irritants. So these can be problematic basically for anyone. It causes an irritation of the nose, but it can also cause your allergies to flare up. So probably the most well-known ones are smoke, air pollution, and then do not forget about cigarette smoking. Even vaping is now the new kid on the block. That is terrible for allergic rhinitis sufferers, for asthma and allergic rhinitis. These can do just as also a lot of damage compared to cigarette smoking, and it's not necessarily safer to vape compared to to cigarette smoking. So even strong odors or cold air can cause what we call vasomotor rhinitis, so it can cause nasal problems. So how do we manage allergic rhinitis? Well, like anything in allergy, we do a stepwise, or we use a stepwise approach. And we've got these 5 pillars that we normally look at. The first pillar is environmental control, then we have education, pharmacotherapy, allergen immunotherapy, or then specialist referral. And the first one, environmental control, shouldn't be forgotten, because that's often forgotten by people. It should be relevant, specific. It can be seasonal or perennial symptoms that causes your allergic rhinitis to flare up. So that should be kept in mind. Is it indoor or outdoors? And then specific strategies should be tailored or specified to that specific allergen. Do not tell patients to rip out the carpets and sell the cat and give the dog poison if you're not allergic to these things, because then you're probably going to have a very unhappy patient. House dust mites, remember that we talked about the HEPA filters that you've seen in the EFSA ads before this. Impermeable mattresses, duvet and pillow covers are important. And then removing carpeting, especially in the bedroom, is usually a good idea if you are allergic to that. And then bedding specifically, we're looking at detergent, bleach, and repeated washing. What about education? So now that you know your allergens, you also can then educate your patient or get educated on specific allergens that's bothering you or causing you symptoms. Remember that ongoing allergen avoidance is very important. It should happen at every doctor's consultation. You should education of your patient should be shared decision making. So basically, you tell your patient what medication they should choose and what medication how they should use it. But your patient should also be involved in this whole decision making. Remember that your patient should understand there's no cure for allergies or your allergic rhinitis. We just give patients symptomatic relief, and then really apart from aeroallergen immunotherapy, there's no specific cure. It's a chronic disease, and don't forget your asthma. Asthma is often linked to allergic rhinitis in 80-90% of cases. And then written material is more efficacious. Remember, ask your doctor to give you a printout of specific instructions on how to use your nasal sprays with your physical demonstrations then on it, and then how to avoid your allergens. What about pharmacotherapy? Before we start, we must determine how severe and how frequent are your symptoms. So we use this classification to just determine where or how high should we step up with your treatment. If you have symptoms 4 or less days of the week, and or 4 or less weeks of the month, then we call you a mild allergic rhinitis sufferer. And then if you have normal sleep, it doesn't interfere with your daily activities or sports or leisures, you have normal work and school and no troublesome symptoms, you suffer from mild intermittent allergic rhinitis. On the other hand, if your symptoms becomes more severe, like most of our chronic rhinitis or allergic rhinitis sufferers have, if it becomes more severe, more frequent, then we call you a moderate to severe persistent allergic rhinitis symptoms. So those patients often have problems sleeping, they have problem with their daily activities, their leisure, and they have abnormal work or school performance with really troublesome symptoms. And then we can decide on the stepwise management. So for the mild intermittent patients, we tell all patients, doesn't matter how severe your symptoms are, that you should recognize symptoms very early, take your medicine every day and know how to use them, what your technique is of your nasal spray and your allergen avoidance. We tell all patients to avoid irritants and then to undergo skin testing and allergen testing so that we specifically have tailored or specifically focused allergen avoidance strategies. So for your mild intermittent patients, not so regular, not so severe, you can use an oral non-sedating antihistamine, and this is very important. This is a non-sedating antihistamine, not something that will make you drowsy or have poor concentration, or something like a leukotriene receptor antagonist. If it becomes more severe or more frequent, you should always use an intranasal corticosteroid. And we also have access now to combination therapy. I'll tell you about that in a minute. So there you can add that onto an oral non-sedating antihistamine or the leukotriene receptor antagonist, but really your intranasal corticosteroid is the mainstay of your treatment. Then the more severe you get, then you'll move on to step 3. There's your intranasal combination therapy. I'll talk to that in a minute. And then your most severe cases, we often continue with your intranasal combination therapy, and then we consider something like immunotherapy. So that's where we give a patient specific injections for a 3 or a 5-year course to try and desensitize them to that specific allergen. If you have a flare-up of your nasal symptoms, if you have a viral or a flu infection that causes all of a sudden your nasal symptoms to get worse, you can use for a short amount of period your decongestant, something like Iliadin, and your washouts. And for a temporary time being increase or step up with your local nasal corticosteroids. There is a small block there on the bottom that says oral corticosteroids. For me personally, I'm not a huge fan of using oral or systemic corticosteroids. These have serious side effects, specifically if you have continuous or recurrent causes of that. So please stay away from oral corticosteroids. We use topical corticosteroids, which is then safely delivered inside the nose. And then this is your combination sprays that I mentioned. Your intranasal antihistamine and your intranasal corticosteroids are nowadays in a formulation where the two are combined. And then really the advantage of this is you have a quick onset of action with a longer onset of anti-inflammatory relief. So we kind of address both of these very important aspects of treatment at the same time. Unfortunately, these nasal sprays are a little bit more expensive. They're not available in all facilities or levels of healthcare in South Africa, but it's certainly worthwhile to ask your doctor about combination intranasal corticosteroids, which are safe and provides quick onset of action relief. So how to use your nasal spray? Remember, if you don't use your nasal spray correctly, this whole exercise is kind of futile. It's important to clear your nose before you use your nasal spray, get all that snotties, and that's where a nasal washout or a saline washout comes in very handy. So before that, do that. Shake your nasal spray very well, and then we teach patients to bend slightly forward and then inject to the sides of their nasal passages. That's where you're really supposed to deliver your nasal spray. It's important not to spray towards the middle part of your nose, because then you're going to cause irritation to your nasal septum. So you should spray inward and kind of outward. And then after that, you lift your head up and try not to sniff. So you just gently wipe your nose clean and you don't sniff. That's really the way that you should be using your nasal spray. Your nasal rinse, on the other hand, is really a more dramatic or a more forceful way of cleaning your nasal passages. It washes away all that nasal snotties and it washes away all that allergens. There are commercially available mixes that you can use, or you can use your own home mixture, where you use a clean container. You take 3 tablespoons of iodide-free salt, and you mix it with 1 teaspoon of bicarbonate of soda, and then from that you take 1 teaspoon and you add it to 250 ml of lukewarm or distilled water. Remember, it should be cooled down or kind of room temperature. And then you insert that, or you spray that into your nose. So while you're tilting your head to the one side, you use the other nasal passage, and then vice versa. So it should really be the nose that you inject the nasal rinse into. On the other side is where your nasal rinse then come out. And that's really an effective way to get your nasal spray working, or your intranasal corticosteroid also working much better. So remember, just some final remarks. Allergic rhinitis is extremely common. We now know that up to 30-40%, that means 4 out of every 10 people have allergic rhinitis or hay fever. It significantly impairs or have an impact on a patient's quality of life, and recognition really relies on a clinical history. So it's not a good clinical condition where you have physical signs. You do some, but a good clinical history from your doctor is important. Get tested, know your allergens, and know how to avoid them. Specifically look at irritants and specifically look at things like cigarette smoking and vaping. The cornerstone of treatment is regular use of your prescribed medicine, and the more severe your symptoms, then inhaled corticosteroids becomes the mainstay of treatment. And for those smaller number of patients that really suffer with ongoing symptoms, remember that they should probably be referred for either immunotherapy or some other systemic treatment that we can offer. Thank you very much.
Thank you, Dr. Duval. I do see that we've got some questions coming through, but in the
Yes.
interest of time, I think we should move on to Dr. Naidu's talk on recognizing conjunctivitis, and then we
Okay.
can start tackling those questions once we reach the questions and discussions. Dr. Naidu,
Excellent.
over to you.
Thank you so much for joining us. It is a cold morning in Cape Town. I'm probably going to put my camera off. There's a little bit of sun that's causing a glare that's a bit uncomfortable for me. So I will put my camera off shortly, but I just wanted to introduce myself. I'm Shirani Naidu. I am a pediatrician with an interest in allergy, and I work at Red Cross Children's Hospital, which is where I spend most of my day. So my talk that we're going to be talking about recognizing and treating allergic conjunctivitis. And I'm very lucky that I followed on from Peter because he's actually done a lot of the hard work of setting the scene for me. I'll put my video off now. So the hard work of setting the scene and talking about these allergy concepts has already been done. So why are we having this talk? One, because allergic rhinitis is common, and allergic conjunctivitis is also very common. We know that it is common in the world, common in South Africa, and that the environmental triggers that are common in allergic conjunctivitis are extremely common in South Africa. We are blessed with a lovely climate. We have a growing season that extends through much of the year. And those things and those positive things for us mean that we also have a lot of these conditions. And those two things go together and we can't actually separate them out. So the second reason why is allergic conjunctivitis common? And Peter has explained a lot of the allergy concepts to you, but the simple truth is that the eye is highly exposed to the outside world. It's closely aligned to the nose in that its location is right next door. And the skin, the epithelium that lines the two organs are very closely linked with each other. They are very, very, very similar. So the eye and the nose close together, highly exposed to allergens. They are in fact the first port of call. If you breathe something in, the nose is the first organ that it is affected by it, and the air from the outside world reaches your skin and your eyes first up. So the percentage of people, the actual precise prevalence of people with allergic conjunctivitis is poorly understood. Most of the research that's done thinks about allergic rhinitis and conjunctivitis together. And there's a certain difficulty about measuring the numbers that I am alluding to in the slide that I'm showing you at the moment. Eye symptoms are not limited to allergic in their origin. There are three big groups of people, and we'll talk about them briefly before we hone in on allergic conjunctivitis. There are people with medical conditions that involve the eye. There are people who have other allergies who have eye symptoms, and there are people who only have eye allergies. And this third group is a very important group to keep in mind. So medical conditions with eye symptoms, these are really important because they need a specific therapy. And it leads to an important disclaimer that we must make about these webinars and use of the APSA website. These are really meant for education and allergy empowerment, but they don't replace a medical consultation. So there are times when eyes have infections. These are particularly viral infections or bacterial infections. They can be sticky yellow-green discharges and often start with one eye first. A viral eye infection often has a watery discharge. With some respiratory tract infections can be very, very contagious and can have burning and pain. So if you have asymmetrical symptoms, one eye more than the other, always think about having a medical consult. There's also some very common conditions in Cape Town, for example, tuberculosis, that have eye symptoms that need a specific treatment. There's another group of highly important conditions where they are either very common or very serious. Dry eye on the right, for example. Common in older adults. There's a gritty feeling that worsens with screen time or time, can very easily be treated with non-pharmacological things, which is also to echo what Peter said, where you can have some kind of eye lubrication, a easy thing to diagnose and very easy thing to manage. And then on the left, we have autoimmune conditions that run in families, can affect more women than men, can often present with arthritis, but can have many presentations and can be a real puzzle to work out. This is important to me, and I like to mention this in my talks because I have a family member who struggled for many years before having an eye doctor prescribe what could have been a life-threatening condition. So again, an eye symptom can be a window into your whole body health, not only allergic conjunctivitis. But the vast majority of people who have symptoms actually have allergic rhinoconjunctivitis, which is that common condition that is very similar to the topics that Peter discussed, but they have a strong preponderance of eye symptoms as well. This represents the majority. They are inherently allergic individuals. They quite likely have other atopic conditions. So in addition to their eye symptoms and their nose symptoms, they may have asthma, they may have eczema, and the severity of their eye and nose symptoms often cycle. Different times of year, different exposures, and we could have sometimes where eye symptoms are dominant, sometimes where nasal symptoms are dominant, but they cycle through the year. Now, Peter has already alluded to quality of life, so I don't need to belabor that point. But it is an important thing because a decade or 2 or 3 decades ago, these symptoms would have been ignored. They would have been, you're not dying, you must live with it. But this cumulative effect of quality of life symptoms has a strong negative impact on children. And as I go through some of the symptoms, I'm going to pick this up for you so you can see how these type of symptoms have long-term effects. So what are the symptoms of allergic rhinoconjunctivitis? Itchy eyes. In itself, possibly a small thing, but the effect of long-term sleep is really important. Redness, it's usually both eyes. And I really would like you to look at the picture on the left, where you can see the difference between this picture and the eye that has infection. This is a healthy-looking eye with a diffuse redness, and you can see when you look at the eye surface that it is swollen. So it can have possibly some itching and burning, but there should not be eye pain. There's often a clear watery discharge. There should not be any effect on your vision, and the swelling of the eyelid is actually it's quite characteristic. Now, if we go to photophobia, which is a discomfort with light, this is a key symptom of allergic conjunctivitis, and we often disclaim it. But all of us, myself and yourself included, are sitting around a screen at the moment. How much time in our modern lifestyle compels our children and our young people to be concentrating on a screen? And the effect of photophobia, itchy eyes, burning eyes, and poor sleep is really catastrophic on days lost to education and vocational training. And while 2 or 3 decades ago, this might not have been as important now, right now, our young people simply cannot afford to lose time to their schooling. The classic look of the child with allergic rhinoconjunctivitis is again, and Peter would have showed you similar pictures, they would have eye and nose symptoms concurrently. Now, what are the patterns or the symptom profile that we see? And there are 2 big kind of groups of how patients can present. There's the seasonal group where you are tightly tied to the pollen season, tightly tied to your nasal symptoms when your eyes are troubling you at the same time as your nose is troubling you. And these can be days to weeks of the month. It would be days or weeks of the year. It would occur yearly. And that's the kind of pattern that we see in many of the articles and the projects that are done in Europe, where you've got a very cold winter that then gives way to a beautiful spring with a sharp pollen uptick. The more temperate parts of the world where we don't have those very cold winters, but we have a warmer here all year round, tends to have waxing and waning. Symptoms come and go, milder but more chronic. The pattern of allergens that spark these kind of symptom patterns tend to be more indoor allergens, but definitely with a seasonal uptick, depending on what your allergen profile is. And it waxes and wanes through the year, but eyes and vision are normal. There are more severe forms of ocular allergy, and these are very important for these webinars as well. The majority of patients fall into allergic rhinoconjunctivitis, but for those people who would possibly need to know about these forms, these are important. These are distinct patterns. They are less common. They overlap with other atopic conditions, much more than previously thought. There was an idea about 10 or 15 years ago that you only had the severe ocular allergy, but we are learning more and more that as the immune system works together, allergic conditions also work together, and they very rarely run as a one condition, and more likely run in packs together. These serious forms of ocular allergy have a more significant symptom profile. They can affect vision in the long term, which means that team management is absolutely critical. There must be an eye specialist in the team that is managing these individuals, and medication that we need to control these symptoms often required to be slightly more stronger to be plain, and they might have a slightly stronger side effect profile as well. These need to be balanced against symptoms that are harder to control, which is why I stress the strong team nature of the patient with severe ocular allergy. There must be an eye specialist that is part of that team. You're going to see that this is a very visual field. A lot of these conditions are determined by how they look, and I'm going to be showing you pictures of these. This is one of the classic forms of severe ocular allergy. It's called vernal keratoconjunctivitis, very common in the countries around the equator, and that is the entirety of our continent, into South America and into India as well. So this condition it's almost like cobblestones. If you look where my cursor is at the bottom left, you can see these cobblestones inside the lid. You can see these almost like jelly sweets around the limbal area, and you can see this kind of hazy look to the cornea. This is very important. If you have anyone in your family who has something that looks like this, I would urge you to make an appointment with your local healthcare provider for a consult. Atopic keratoconjunctivitis, also a very characteristic look. These patients are strongly associated with eczema. These two things run very strongly together. Again, you see very different from the innocent allergic rhinoconjunctivitis in its look. You see that the eyelid is affected, the eyelashes are stringy, the eye itself is cloudy, and this kind of pattern of distended eye blood vessels are very distinct and very, very different from the swollen but healthy allergic conjunctivitis that I showed you earlier. So again, if anyone that you in your family has something that looks like this, I urge you to make an urgent consult. So in terms of treatment, Peter has already alluded to the four big pillars of education, of non-pharmacological treatment, pharmacological treatment, and allergen avoidance where necessary. So I don't need to go into that. For these allergic conjunctivitis, the more mild your symptoms are, the more important the non-pharmacological treatments are. They can really, really make big difference into quality of life. And I would urge you to ask your healthcare provider to go into those with you. And those include allergen avoidance, importantly, eye hygiene, tear substitutes, just lubrication of the eye really does help with that feeling of dryness. And to treat all other conditions, allergic rhinitis strongly associated with seasonal and perennial allergic conjunctivitis, and then VKC and AKC to treat any other condition that may be there. In terms of medications, we will see that the same names apply that you would have heard for allergic rhinitis. There are agents, the mast cell stabilizers and antihistamines are the same names that turn up, but these are actually topical. They are directed at the organ that is involved, directly applied. And because of that, you can get by with quite low doses of it. And they have a very favorable symptom profile in terms of being absorbed into the body. So these are some common agents that I'm showing you. But there's a few things that I have to also tell you about in terms of agents that you will not see on this slide. Over-the-counter eye drops. There's a little bit of a word of caution that I need to give to you there. It's easy to get hold of them, so many people are tempted to just go to the pharmacy and get something to make their eye feel better. Now, these over-the-counter drops, they only actually shrink those little blood vessels. They give you temporary relief, but they don't do anything to the underlying nature of your condition. Peter spoke through the kind of the scientific and concept of allergen exposure very nicely, but it's good to keep that in the back of your mind. These type of vasoconstrictors don't do anything about the underlying cause of your symptoms. While they're nice to use because they're nice in a fix, they don't actually change the cycle of chronic symptoms. Not terrible, but not useful in the long term. I also have to say something about steroid eye drops. Now, we know that steroid nasal sprays are the mainstay of treatment for allergic rhinitis. Very well established, very good symptom profile, and really they've become life-changing in that condition. For allergic conjunctivitis, steroid eye drops need to be used with a slightly higher level of caution. There are eye-based complications that include infection risk and include eye pressure. And this is why I started off by saying, if you have a slightly higher level of symptom control, there should be an eye specialist involved in managing your symptoms because they would need to manage those side of your symptoms. Some basic tips. I've spoken about these being medication that we give directly to the site of the symptoms, and in this way, allergic conjunctivitis is strikingly similar to asthma. Again, we make sure that the medication matches the site of the inflammation so that we can control symptoms as efficiently as possible. Few tricks. Our colleagues in ophthalmology encourage that we refrigerate the drops. They're slightly better tolerated when they are cool, and also that you prepare the person that's going to be using them. They sting a little bit if you are unprepared for it. So it's good to speak to the person that you're using it. It's best if you try to aim your drop to the top corner, if you can see where my cursor is, and that's kind of the best way to introduce these drops into your eye. So the take-home messages, if I can conclude my little whistle stop through allergic conjunctivitis. Eye symptoms are common. They're not all allergic related, but they very commonly are. Most of eye allergy is related to nasal allergy. So allergic rhinoconjunctivitis is the dominant clinical phenotype in this group. A good examination is often more useful than testing, and you've seen that by the number of pictures that I've showed, and this really is what would happen in a consultation. Treatment mostly is delivered directly to the eye, the most efficient way to control your symptoms, and that kind of reflects the treatment philosophy, the minimum amount used to control symptoms. For allergic conjunctivitis, we have to treat the whole person, not just the eye. We've got to make sure that we have the right diagnosis, that we haven't mistaken allergic symptoms for something else, and in the patient with allergies, to make sure that we've properly assessed the whole of them, kind of concentrate only on the eye, and miss the allergic rhinitis that often, or asthma or eczema that may be coexisting in that patient. So treat the whole person, not just the eye. And I'm going to finish off. That's our first talk, and thank you to our sponsors who've made it possible for us all to be here this morning. Meg, would you like me to move directly to the next talk?
Yes, I think we can, Doctor. I think we can move into the resources talk, and then we can tackle our questions and discussion session thereafter.
Are you seeing it properly now?
Yes, you can just stick it into slideshow mode, full screen mode. That's perfect.
Fantastic.
Yes, it is.
All right. All right. Excellent. So when I got this topic, I spent a little bit of time thinking, what would make me give up a Saturday morning to come to a talk like this? And I realized the only thing that would make me give up my Saturday is this picture. I think this for many of you, and to be honest, for myself as well, there are people in my family who struggle with both, with in fact the entire gamut of allergic conditions. And really, these are the things that motivate all of us to come and listen and try and figure out how we can be more knowledgeable about these conditions that are important and more helpful to the people in our life who need assistance. So, what are the things that you might be looking for? What are the resources that you might be interested in finding out? And I thought there's kind of 5 big things that people are interested in. There's knowledge, there's training. You might be looking for support. You might be looking for more information about danger signs or how to predict them. And you might be looking for some help with triggers. And that's kind of, I thought, like, if that's what I would want to need, how would I help you navigate your way through that? So, first of all, little things about APSA. So, the South African Allergy Foundation was established to create awareness, to advise and educate patients, to promote responsible care, to assist with advocacy, and to raise funds for professional development. So, that's the first thing. So, who is APSA? What does AFSA do? And a big part of what AFSA does is kind of centered around the website and the resources that are in there. So there are some really, really useful things, but I've already given you the disclaimer. The content on the website is not intended to be a substitute for that medical consultation or that relationship that you have with your healthcare provider. So there's social media, there's the newsletter, there's the support groups and Facebook, there's the blogs, and there's the professional search tool, all of which very useful tools. But what kind of knowledge are you looking for? Sometimes you actually only need to have a little bit of knowledge about something, like these little blogs that you can find. At the bottom is the landing page. So as you come into the website, you'd see the kind of the overview, and then you can click on the different tabs. When you click on these tabs, and I'm not sure if you can see my cursor, this, for example, is when you click on allergic diseases, allergic rhinitis comes up, and it gives you a little snippet of information. And for many people, that is all you need. For those of us who want a little bit more information, there are also the leaflets that you can download and you can read through in more detail, because this is for someone who needs to know a little bit more. You need to know what the symptoms are. You need to know what the triggers are. More than a 30-second read. So these are beautiful. I speak to a lot of patients, and sometimes I have to give them distressing news that they didn't accept. And you note that in that consultation with your healthcare provider, you often don't take in all the information that you need. Then you go home and you go, oh, gosh, this is what I needed to ask. This is such an important question. Why didn't I ask it at the right time? These leaflets are so important because you can download them, you can go through them, and often they trigger memory. Oh, yes, they did ask that. They did tell me about this. Or you can create a little list of follow-up questions for your next consult to make that second appointment much more useful for you. So knowledge is important, but not knowledge to make yourself an expert, just enough knowledge to make yourself empowered to know what are the right questions to ask your healthcare provider and how the two of you can take your relationship forward. So then the second thing that comes up very commonly is how to use the medication correctly. Often you'll go home and you'll get this little device and you'll open it up from the pharmacy and you'll go like, what the heck must I do with this? So training on how to use medication prescribed is a huge value add for the family. You will recognize this from Peter's talk about the nasal spray. This is a detailed little examination with a little diagram there of how you can use your spray. It's very difficult to negotiate with a 4, 5, 6-year-old who doesn't want to use their spray. But you can show them the pamphlet and go, this is what we're going to do. It's not going to hurt. You're going to see it's going to be okay. And preparing your child for something that might be unpleasant is so much more useful than forcing them. And then there's the crying, and then there's, I don't want to do this. These are not the things that you can do for long-term chronic medication that you're going to have to give for years, if not decades. So how to use your devices, very important. This is one for the nasal spray. This is one for the nasal rinses. That's quite important. There's one even for some of us are not people who like to read. Some of us are visual people, particularly children. They like to see what's happening. So in the same APSA website, they have these embedded videos which you can play for your child or your teen, whoever it is or your spouse, whoever it is the person that needs meds, to actually show them how you're going to do things. Sometimes, even with the best of training, people are not managing with their devices. And APSA has actually been involved with some novel device development. For example, AfriSpacer, which has made it easier for people, children or adults with disability, children with disabilities, to actually use their space in a better way. So this is a very exciting space that APSA has been involved in. So we've talked about knowledge. We've talked about support with how to use your medication. The next big problem is support with how to take your medication regularly. We all have busy lives. We've got things going on. You've got to get up. You've got to get the house sorted. I had to sort my own household out this morning before we started this webinar. So be regular with your medication. The word we would use in medicine is adherent. It's really, really hard. And there are a couple of ways you can go about that. The social aspect of the APSA website is very useful. Social media, the support groups are very, very useful because those are other people like you who are living with people who have got an allergic disease. Finding a good fit with a healthcare provider, that's also very useful. So this professional search tool to have a supportive partner in your healthcare provider is really important and can help you walk this journey more successfully. But there are also other tools on the APSA website that you can repurpose for allergic rhinitis and allergic conjunctivitis. This is an asthma diary, but you can repurpose it to use many, many things. For example, every time you take a medication, you can put a tick on it. Then you look at it at the end of the week and go, only 5 ticks this week. Next week, I want to make it 6. You can do the same thing with the diary on your phone. You can set an alarm so that you can remind yourself about it. Another useful way to use this diary is to make a tick whenever you've bought a new dose of your rhinitis spray or your allergic conjunctivitis little bottle of drops. So if you've made a tick on the 1st of July and it's now the middle of August and you go, I haven't been very good with taking my meds. It's a very useful visual reminder. You can put it on your fridge with a magnet, and it really does help guide you as to how good you are at keeping yourself accountable with reliable use. And all of these meds only work well when you take them. So the other thing that patients often need help with is kind of recognizing your own pattern. What are your own danger signs? What are your own triggers? And again, our friend the asthma diary can be repurposed for this. It's very useful to track your symptoms and you find your patterns, and then it can help you identify significant triggers. So in Peter's first or second slide, he actually went through the whole range of allergens and triggers that can be causing symptoms. And this is really important. If you just think about your eyes, they are so exposed. I've worn glasses since early in my life, so I'm a little bit protected, but mostly your eyes are one of the most exposed organs in your body. And grit or an environmental exposure or chemical, there are so many things that can trigger symptoms. Allergen avoidance is only useful if it is a relevant trigger. We can do skin tests and we can do blood tests, but we cannot test for everything. It's one, clinically useless, and two, extremely expensive to follow that kind of method of testing. Far more important is if you do this for yourself, kind of find your triggers, work with your healthcare provider, identify what is setting you off, and that allows focused allergy testing, which is far more useful in the long run for getting control of symptoms. Once you have confirmed allergens, then there are also, as Peter alluded to, there are several things in the AFSA shops that might be useful for your confirmed allergens in terms of avoiding those. So I'm going to wrap up by saying there are many resources that AFSA can offer to you that are going to help you to get control of your allergic rhinitis or your allergic conjunctivitis. Some are big things that don't involve patients, like advocacy with medical aids, advocacy with drug companies. Some things are really technical, like the clinical trials. The other things are involving projects, fundraising, donations, World Allergy Week that's actually just passed. But please sign up for the newsletters and the updates and find the resource that suits you and that's going to bring value to your life. So thank you, and I'm going to stop sharing at this point.
Thank you so much for that talk, Dr. Naidoo, for both those talks back to back, as well as to Dr. Duval, who kicked us off so perfectly with his recognizing rhinitis talk. We are now entering into a questions and discussion section of today's program. And I know that Dr. Duval has been answering questions. So I'm going to invite the audience to post or continue posting questions rather. Dr. Duval, you've done well with answering all of those questions. I wonder if there are any that yourself and Dr. Naidoo have perhaps identified that you'd either want to elaborate on a little bit. So I'll just give you a moment or two. I'll pull up just a holding slide for us while Dr. Naidoo just reviews what's been going on in the Q&A during her talks. So to the audience, thank you for those questions, and I encourage you to continue posting your questions. Also want to just draw your attention to the resources tab for access to some of our handouts, as well as the live links that will take you directly to the Allergy Foundation website. Lots and lots of useful information. Go and familiarize yourself with what we do and what we offer.
Thanks, Megan. Sharani, maybe you can help me with this one. Nikita was asking, my son has congenital glaucoma, so it's really difficult to treat him with any cortisol treatments. And unfortunately, most treatment involve some sort of cortisone. Do you have any advice here?
First of all, I'm going to say I was struggling to find the chat, so Peter, I'm going to ask you to read them out to me. And I'm going to say to Nikita, this is, Peter and I have kind of identified ourselves with our background. The congenital glaucoma and steroids is a huge challenge because your child is already riding the edge of intraocular hypertension. So I wouldn't say that steroids would be an absolute no forever, but the modern way of treating allergic conjunctivitis is burst steroids. So what they do is they do like a burst of it, like very much like analogous to asthma. So they do a short course with very tight control. But there are other drugs like the multimodal antihistamines and mast cell stabilizers. They are very effective, even in the severe forms of ocular allergy. They are first line. So it's not that we don't have options. They are the non-pharmacological, they are the first line agents. And then there are the third and fourth line. So for most people, we go first, second, third. Your child has got a good reason for skipping step 2. But there are step 3s. Now, the step 3s I didn't go into my talk because they are slightly more difficult to access. One, there's not a lot of meds. They are a little bit finicky in that they do sting a little bit more, and they're not always acceptable to a lot of our young patients. They're a little bit more costly, and they're a little bit more difficult to access because some of them have to be made up in specialized pharmacies. But definitely the third line agents, for example, the immunomodulators, are available. I would ask that wherever you are, you contact a pediatrician or pediatric ophthalmologist who can guide you. Your child's condition is a little bit more complex, but definitely not options. You have many options. Even systemic antihistamines are not unuseful for people with allergic conjunctivitis. They cause dryness, which is a little bit counterintuitive because the dryness and itchiness is part of the problem. So there are lots of ways to skin a cat. Your child just needs a very finely tuned way forward, very close monitoring. There's going to be no way to divorce yourself from your ophthalmologist. The two of you are together for life, because that intraocular pressure needs to be closely monitored.
Thanks, Shirani. And then the other question that I see here, why are we not always warned about steroid medication causing cataracts?
That is a very interesting thing. Hey, that is a very interesting thing. Part of the problem is that the cataract risk is not linear. Like, we are used to like a drug have a predictable response. Like 1 day of steroids give you 2% risk, 2 days gives you a 4% risk. The cataract thing is not linear. It's a little bit unpredictable. And there are many things, genetic things, whatever, that gives you a high risk. Atopic AKC, for example. If you've got AKC, your steroid cataract risk goes up through the ceiling. It's just one of those things about that particular kind of allergic conjunctivitis. Increases your cataract risk exponentially. So it's hard to know what to say to people because the risk is not the same. The risk is so highly variable. Does it exist? Absolutely, it does. Should it be monitored? Absolutely, it should. And I think that is probably why the way of thinking about steroids changed because they used to be given back in the old days, and Peter and I will remember those days where we dished them out a lot and people used them like daily. Even in asthma, there was a lot of regular oral steroid use. But as we've learned about the risk profile, modern treatment profile treatment patterns have changed. For allergic conjunctivitis, regular steroids has become burst therapy, short, sharp, control your symptoms, back away from the steroids. And if you use things in that way, with using our other good modern drugs, particularly the antihistamine and the mast cell stabilizer combinations, you can get away with that with very little steroids over the long run. And if you do, again, we must make sure we're dealing with that we're treating the right thing.
Thanks, Shirani. And then Eva van Bell is asking, Shirani Naidu, do you also see patients privately? Seems like you're in demand this morning.
I did. I was in private practice for many years, but since I've moved back to state, I think Peter will understand when you're in practice, you need to give your patients your full time and attention. So to do both, I found was like everybody lost. I lost, the patients lost because they didn't get enough of my time and attention. So I stick to the one. I think it's better for me, it's better for my patients. I miss it though. Because I looked up to some people for years and I knew them and I knew their patients, and it really was very rewarding. But yeah, I think I'm also happy at Red Cross.
And then Courtney is asking an important question. Is it true that cortisone ointments thins the skin? And I think the answer, Courtney, yes, absolutely. And that's why we should keep a very close eye on the length, first of all, that you use, or the duration of your topical corticosteroid use, but also the strength. So we spend long hours trying to study different strengths or names of strengths and to give it to you safely. So I think an important thing here is not to put someone on a topical corticosteroid cream and then see them again in 6 months. I think it's important to up. It's like a lot of treatments in allergy. It's a dynamic treatment. You step up and you step down. The same with asthma, the same with allergic rhinitis. We try and play it safe. So yes, absolutely. Unfortunately, there isn't something more effective than topical corticosteroid cream currently all over the world for atopic eczema, first line treatment. So absolutely, it does thin the skin. It does have side effects, but that's where you should monitor your treatment.
AKC has got a little bit of a problem. I don't know if you remember the picture I showed. There's often eczema along the eyelid as well, which is really hard to treat. And the drops don't address it, and you sometimes do end up putting steroid cream on very thin skin, with a great
Yeah.
deal of anxiety and caution. But that particular, there's very little you can do about that because until you
Mm.
control the eczema, the eye continues to struggle. So that's a conundrum, but Peter has answered exactly the dilemma. You have to go forward to control the symptoms, but with extreme caution.
Mm. Chantal is asking, what are the key signs of sleep apnea? Do you want to answer that?
Um, Sleep apnea is an interesting one because there's a continuum, of upper area obstruction, of snoring, and everybody complains about the loud snorer. So the
Mm.
sleep apnea is the person when the loud snoring is starting to tail off, the volume is dropping, the quality is dropping. It becomes more of a interrupted gurgling type noise. And as you go from snoring to the more obstruction, and obstructed would be that kind of gurgling, choking type noise. Sleep apnea is the end of that continuum, where the snoring has progressed to upper airway obstruction, to the person who now has interrupted breathing while they sleep. They often shift position, they wake up distressed and short of breath. And the most extreme example is the child who is sleeping, becomes quieter, wakes up, startles, sits up. That is the person who needs great deal of watching because that means they can't sustain oxygen in their blood while they're sleeping. Their body has recognized that and has actually made them wake up. You can imagine the effects on their sleep quality. You can imagine the effects of their behavior, their temperament, their school. Peter has shown you that example of the worst end of that spectrum, where the changes in your breathing have actually affected your lungs and your heart. Um, we've all unfortunately found patients in our wards like that. So even though it's a rare complication, it's not unheard of. Um, so sleep apnea is an important thing. I just need to distinguish sleep apnea in children from sleep apnea in adults and adolescents. In adolescents and adults, there's a lot of things you can do to improve things, reflux, weight, etc., etc. In children, because of the small size of their airways, their noses are small, their midface is small, we have a lot less options. And we depend a lot more on our colleagues, the pulmonologists and the ENT surgeons, to help us navigate that tricky period of upper airway obstruction in a child under 5. It's very tricky. Medication can take you so far, but you need very close consultation between your pediatrician, your pulmonologist, and your ENT surgeon to try and decide when is the place that you're going to intervene. If the question was about technology assists. There are technology assists. There are CPAP masks and breathing assists that people can use at night to help them breathe. I know it's more commonly used in adults who have CPAP masks. We have at Red Cross a few children who do need sleep assists, but it's quite an invasive thing to do, and it requires it takes a lot from a family to manage a medically complex child who needs technology. So we really try to avoid getting to that. We really try to make sure that we can manage it more aggressively rather than asking a family to have a breathing assist. Not impossible. Nothing is impossible with a family, with a mom and a dad who are motivated and are all in to support their child. We've done it with many kids, but it is a big ask for a family. Did that answer the
Eva?
question?
Yeah, no, I think so. Often the person suffering from obstructive sleep apnea doesn't know they have it. You must ask the husband or the wife, and then they will tell you that they need to kind of hit them in the middle of the night to start breathing again.
The best history is from the siblings because they have
Yeah.
no kindness. They throw their sibling under the bus, often with the
Yes.
dramatic reenactment.
Yeah, absolutely. Eva's asking, do you know an ophthalmologist maybe in the southern suburbs? I think we can't really give out names of specific people on this platform, Eva. Unfortunately, we can't because that will basically count it as advertising. But I think start with your immediate physician or your immediate house doctor or your regular general pediatrician, not pediatrician, general practitioner. and then maybe ask him for a good referral. Obviously, Dr. Sharani will know ophthalmologist, but unfortunately, we can't give specific people or promote specific people here. Now, Wal is asking, why is CPAP so expensive? Sharani, do you know? I don't know. I
Um,
guess it's a
I
company
can
driven thing.
agree. It is very expensive because I mean we go through a lot at the hospital. Um, I really don't think Peter and I are the best to. I mean, we like you, we are also on the recipient end of that. We're not in manufacturing at all. Um, I
Mm,
don't know. I just sigh at the price. I never considered that's a very good question.
yeah. Kiriboni is asking a very interesting question that I think a lot of people may relate with. I'm 44 years old, female. Thank you for the session. It's a pleasure, Kiriboni. I've been struggling with sinusitis after having flu. It's been 3 months now. The flu is gone and cured. I've lost my taste and smell, but I have thick greenish mucus, sometimes blackish, like granules, followed with severe headaches. The doctor to be given different nasal sprays, cortisol, oral, and antibiotics. It doesn't really have an effect. I don't know, Kiriboni. It seems like you need to see a ENT specialist here. Sometimes it's important to. We often do not do X-rays or special scans of the sinus cavities, but it may be in your case that you kind of suffering now from a chronic rhinosinusitis, and that kind of needs a more prolonged course of antibiotics and obviously trying to get specifically the organism that's causing your symptoms. So I think just trying to put on the bandage or the band-aid or the plaster to your allergic rhinitis with antibiotics is not a good enough thing. I would suggest specifically a ENT specialist having a good look at you, because it seems like your symptoms are now qualifying as a chronic rhinosinusitis, which needs more important treatment.
and those color changes over such a long time, I do think as a symptomatic thing, possibly the saline washes may help you just
Mm.
to get some of the gunk and to breathe better, but I
Mm.
don't think they are going to be the answer for you.
Yeah. There might be a fungal component also, hey?
Mm,
So we
mm,
often see fungal rhinosinusitis giving this sort of a weird looking color, like almost like a peanut butter kind of color to
mm.
patients. Okay, thanks, Nawal. Nawal is mentioning here almost 16,000 Rand. That's certainly a lot of money.
Really?
So for the
That
CPAP.
is, that
Yeah.
is, yeah.
Okay, I don't see any other answers. Megan, are there specifically something from, or questions? Are there anything specifically from your side? I'm just checking quickly.
No,
Um,
Doctor, I've also had a look, and I do believe we have answered all questions, whether being typed in or in discussion.
mm,
So I will invite the audience, if there are any last questions you'd like to pose, please do so now. If not, we are going to close the questions and discussion section and then move on to the last part of our session today, and that is one of my favorite parts. It's handing out prizes. So if we are not seeing any more questions come in, I'm going to close the questions and discussions slot. Doctors, are you okay with us doing that?
I just want one last question. Mohammed was asking, what about cross-reactivity and specificity of IgE testing? Can we do immunotherapy on the basis of that? That's a good question, Mohammed. Remember that before you embark on the immunotherapy journey, it is not expensive, not unaffordable, but I mean, it does cost a few bucks. So I think make quite sure that and here an allergist comes in quite handy, or is probably the best person to know. In today's age and time, we do have access to what we call allergen component testing, and there you can really try and see if there are cross reactivity to different, often unrelated allergens, and then that specific allergist will then help you to decide whether immunotherapy is the best treatment based on specific IgE testing. So just to tick off a few things on a lab form is probably not going to be a best trick here. A good clinical history is important, and then deciding which component testing is relevant in your case is a good idea. That's just a very important. Immunotherapy is not for everyone. Not everyone can afford it. Not everyone, sadly or unfortunately, has access to it. So before you do immunotherapy, just make sure you know exactly if that allergen is relevant to you, and that immunotherapy is your best way to go. Thanks, Megan.
Perfect. Thank you so much. I'm just going to stop my screen sharing over here. Okay, I'm about to announce the winners of today's prizes. Just give me 1 second. Here we go. We've come to the end of our workshop for today. Congratulations to our 4 lucky winners. Krishna Govender, you've won the Beat Allergy Starter Pack, sponsored by Mrs. Martins, Beverly Owens. You've won the Respiratory Hamper from Glenmark Pharmaceuticals. Diana Mahapi, the product hamper from Kenview will be on its way to you. And Sina Tavani, the Salix product hamper, proudly sponsored by Reitzer Pharmaceuticals, will be on its way to you. Thank you so much to our audience for joining us today. Thank you for those questions. And of course, a huge, huge thank you to our panel of experts for the wonderfully prepared presentations and for handling the questions and discussion section so perfectly. I will contact today's winners in the new week to confirm shipping details. And a reminder that the recording of today's workshop will be made available to anybody who's attended live, as well as to those who may have had to leave a bit earlier or who were unable to join us live today. That link will be shared with you at the start of the new week. A reminder to our medical professionals in the audience, this is not a CPD accredited event. If you do need any additional information about AFSA, what we do, what we offer, what our services are, please feel free to reach out to us. Continue visiting our website to learn more, follow us on social media, and sign up for our free newsletter. Thank you so much for joining us today. I'm going to play us out with a little promo video. And yes, have a lovely weekend. We will see you hopefully at the next session that takes place on the 19th of September with a focus on eczema. Please be sure to keep your eye on your inbox for further communication from us. Have a wonderful weekend further. Take care.